Thank you very much, Robin, and thank you for the invitation to come here and talk to you all, which is really quite an honour. I don't have the sort of emotionally powerful and important messages that we've already heard today, which have been quite remarkable and eye-opening. I also don't have a talk that is surrounded by numbers or science, which is usually what I do present in many of my talks. I've been asked to talk about an experience. That's what you'll hear, and this is your chance to sit back and relax. A lot of what I've said overlaps with what Tim Geraghty has said already, so these messages may be reinforced, but I think that many of you already know it. As a background, I think, as has been said, the H&E or Hunter New England Local Health District, of which Newcastle is a part, has been a pilot site for NDIS. So we've been working with the NDIS since 2013. Hunter New England, however, is not an official provider for NDIA, and this has some implications in the way we interact. The John Hunter Hospital itself, which includes the Rankin Park Centre for Aged Care and Rehabilitation, has approximately 600 beds, which includes the Rankin Park Centre for Aged Care and Rehabilitation, which is about 65 to 70 subacute beds. John Hunter itself is a major trauma retrieval centre and the biggest one between Sydney and the Queensland border and the busiest emergency department in New South Wales. But in our subacute settings, we also have a day hospital, outpatient services and community-based services. So all of these are a part of the interaction and the interconnections potentially, and I like the word interconnections, Tim, that we have with NDIA. So here is Newcastle, approximately 150 kilometres north of Sydney. Top left, we have the John Hunter Hospital where I work, and you can see Newcastle, the city there on the water, Newcastle's harbour, the beaches. This is in the bottom left, Lake Macquarie, where I live, and I in fact live just about there. And the Hunter Valley is well known to many for the wines and the beautiful surroundings. So talking about our experience, from the beginning of our interaction with NDIA until now, what we've seen is a reduced or a reducing budget per client for services. We've seen a progressively clearer definition of the service limits or boundaries that are made available to participants, but these are still evolving. We've seen evolving definitions of what gets termed appropriate referrals into the service, so the people we can refer now perhaps are different from those at the beginning of the service. We've seen that there have been very complex communication pathways between the NDIA and our public health sector, and there would appear to be different priorities between NDIA and the public health sector, and that includes time. So I want to say that I present this information on a background of talking about some of our inpatient services more than anything else, because that's where I have done much of the work, but there are commonalities in the experience with outpatient services and community-based services. It's going the wrong way. So to try and improve some of the way we work, and Tim spoke about his efficiency, we too have put together a flow chart, and this highlights the importance of working in a team. And the flow chart has been put together mostly by our social work department and is quite an extensive one. And so I'm going back to the beginning. I just wanted to give the overview, but I think in showing the flow chart, it actually highlights some of the context that we have to work in and reflects some of the things that Tim has covered as well. And as has been discussed, as far as inpatients are concerned, people who have got a new onset of significant disability through illness or trauma, we have to start from the beginning. And at the very beginning, we really look to see whether the medical condition is likely to be long-term or permanent. And if so, as a group, as a team, we look to see if the patient is likely to be appropriate for NDIS support and if it's going to be required at time of discharge. We then work with the person with disability and their family to see that they understand what NDIS can offer them and what the role is, and seek their permission to commence a communication with NDIS from the beginning. And we also need to work to get their consent for us to communicate with NDIS, because otherwise, due to privacy issues, it can only be between them and NDIS. So this is a very important part for us and for them to understand what our role is as an advocate and a negotiator, and to simplify their pathway for what can be a complex journey. The next stage is to email the request forms and functional reports and a medical report to the NDIS to try and help deliver the information as quickly as possible, because time is of the essence for everyone, really. I'm going to come back to the medical report a bit later just to help the doctors in the audience see what we have found works better. But we make sure that at this beginning point we have an idea of how long 21 days is, because that is the time frame that the NDIA has given us, that they will determine whether the applicant is relevant to be a participant in NDIA. Sometimes the 21 days can stretch out a bit longer. To us, it's important that it doesn't, and it's also important for our patients. So we continue to work with NDIS and communicate them to make sure that we don't go far over that 21 days. Once they have been approved, however, we then have to start negotiating with our local NDIA office, because the approval that the person is relevant to be a participant is made at a central location. So we then have to start to negotiate with our local service to find out how we can move forward. We request an allocation of an NDI planner and set a planning meeting date. The planning meeting date is said that to be required to be within a time frame which is reasonable. That, as the terms imply, can be a little bit flexible. Whilst we're waiting for the planning meeting, the team get to work with the client and family to try and identify a relevant care plan ready for the planning meeting. The team, of course, is very important in getting this together and completing the Getting Plan Ready forms. We finally do get to have a planning meeting, and at this point we have to demonstrate and advocate that the plan put together is necessary and reasonable, because we are not the final arbiters of this. The NDIA is. And their determination of what is necessary and reasonable is not always the same as ours. Once the plan is considered, our team members work with the planner to help explore scripting of equipment and home modifications, and then the planner has another 10 days to 14 days to complete the plan, and sometimes this time frame is expanded as well, as other things can interfere. Whilst the planner is completing the plan, our team get to work to try and see if we can contact a coordination of support, if that's included in the plan. And that often is the case with many of our patients, because our patients are often quite disabled and require quite complex support mechanisms. And once we can identify the coordinated support, we then have to work hard to start to confirm that the plan is actually approved, then need to identify a service provider, and then start to work with the service provider to prepare for the discharge home. This, together with potential carer training and looking at home modifications, can all take further time. And as Tim has highlighted, ultimately the patient is discharged once the necessary support, equipment and home modifications are put in place. Occasionally patients are able to be discharged before everything is in place. When we did a non-scientific back-of-the-envelope calculation at about this time last year, the average time it took from when our patients were medically ready to go home versus before they could actually go home, before all these things were put in place, average time was in the order of 170 days. So some of the issues that we need to look at include what New South Wales put in as a Disability Inclusion Act in 2014, and different states may have different versions of this. And as NDIS become more national, it may well be that these disability acts become more nationally consistent. Very important act, and the statements that are provided here are important and appropriate. But in the act of putting together a legal statement about disability, we now have a new definition of who is disabled according to legal status and who isn't. And we've found that there are a number of individuals with chronic health conditions who are unable to access a disability service because they're not defined as disabled legally. And this is quite different from the definitions we used to work with and the groups that we had under ADAC, the Agency for Disability, Handicap and Home Care. Our experience now is that with the introduction of NDIS into the management and support of people with a persisting limitation of activity, it's meant that there's been a significant change in the work practices of our team. And that's not unexpected or inappropriate, but we have to be prepared for change, as has been discussed in the past. We can't continue to work like we have. And so the roles of the team and the process of the team have changed in many arenas. This is how we felt at the beginning, and it's not a surprise, but it didn't mean that it was inappropriate to keep working. We've had a lot of positive experiences with this, and many people have highlighted today how important and appropriate NDIS is, and we would agree. There's no doubt that we've had more people able to be discharged back to the community rather than being destined to go to an institution or a nursing home, even amongst the young people. There is more capacity to satisfy client-centred priorities beyond just the basics, and we're able to address quality of life, social and leisure activities and independence. The patient and the family and carers are more involved in decision-making, as has been the catch cry for the NDIS, and is incredibly important. And fortunately, we also have more service providers available, although there are risks around that, as has already been highlighted. We've also faced some issues. We do have more service providers, but many of the people who work in there have limited training, skills or insights into the needs of the more complex health conditions and disabilities and limitations. And it raises the question of who's actually responsible for the governance of those employed by the service providers. There's also many more steps in the process of referral and planning, and more hierarchy involved in the approvals process. There's a lack of certainty now amongst us as clinicians and those working in the health system. A lack of confidence around the funding of programs. The things we start off to work with now may change before our person with disability is discharged or soon after they're discharged. We no longer have control over the process or timeframes, either of which can shift unexpectedly. The NDIS provides services only. In the past, the disability-related services also had a role in providing accommodation. That is no longer the case. And we've actually had nurses and social workers take on real estate agent type jobs from the hospital, looking for appropriate accommodation, private rental for our patients, because nobody else is there to do it. I said I'd come back to the doctor's report, which for the physicians in the audience is relevant, because it's not just a matter of putting in the diagnosis or even the prognosis. And we found we had a bit of a problem getting our doctors' reports accepted for quite a while. Indeed, initially, our reports were readily accepted because they gave us a template. And then they took the template away for reasons I'm not quite sure about. So we just gave the simplistic information, and it wasn't until we started following the template again secretly, so all of this is secret squirrel stuff, don't tell anybody outside here, that they started accepting our reports again. And what seemed to be important was to identify the disability and the conditions. that includes the primary condition, but especially how it impacts on function. Evidence to support how permanent the disability may be, and report from any other specialists. What the current treatment is, and also not just the treatment for the primary condition but any other treatment, and in particular is the treatment expected to remedy the condition or lessen the functional impact, which in our case usually is not the situation, otherwise we wouldn't be referring to the NDIA. And it's important to list referral to any other specialists who are involved. So in summary, as a pilot site, the introduction of the NDIS into Newcastle has resulted in significant benefits, but challenges also. We've seen a separation of health and disability, which is not always to the advantage of an individual for whom you want to have a holistic approach. It's meant that communication strategies, priorities have changed, and we now have separated budgets, which makes it difficult to have a combined service. We've seen an introduction of a whole new workforce, which has positive influences and requires evolution still. And we've had evolving definitions and guidelines for eligibility, process and entitlements. We don't have as many signposts now, but they're clearer than they were, and we feel a bit more confident in terms of being able to move forward. But I'll just, as a final point, comment that as a pilot site, and whatever your thoughts are about what the role of a pilot site might be, we thought it was an opportunity to explore and improve before a final rollout. And we've certainly had many learnings and discussions between our public health and the NDIA, resulting in modifications of the process to improve outcomes locally. But with the commencement of the national rollout, it seems to us that these mutually beneficial changes that we've sorted out locally have actually not been considered or incorporated into the national spectrum. And indeed, we're still told that Newcastle is a special case for how we approach. So that's all I can offer you today, but I'm happy to answer.